and elsewhere across the country. So we are conducting 2 additional webinars this fall as part of this series. One will be held on October 22nd at 2 p.m. Eastern Time. Please mark your calendars. And the other webinar will be in November. Now, once we have the date and time in November, watch for an email or a tweet from me or from Christy Friedman, the center's program manager. Now, in order to keep today's webinar on track, we need to conclude everything by 1:59 Central, 3 o'clock Eastern Time. And what we'll do is we're going to hold the last 20 minutes of the webinar for questions from the audience. Now, please type in your questions in the area designated on your screen. You'll see that on your menu bar. And we'll try to take as many of these questions as possible when we get to the conclusion of the presentations. Now, we're also recording the webinar today, and we'll have it posted on our website as well. And that website is vanderbilt.edu/health workforce studies, all one word. vanderbilt.edu/health workforce studies. So today we have 2 presentations that are going to focus on physicians in the rural health workforce. The first will be given by Doug Staiger, who will describe new research on a major demographic headwind that faces physicians as they are deciding to practice in rural locations. After Doug finishes his presentation, Davis Patterson will come on and talk about training opportunities and challenges that face some medical residents' decisions to practice in rural areas. So let me conclude my introductory remarks by briefly introducing Dr. Douglas Staiger, who is the John French Professor in Economics at Dartmouth and a Research Associate at the National Bureau of Economic Research in Cambridge, Massachusetts. Doug's research interests include the economics of education, economics of healthcare, and statistical methods. In the field of education, he's been working on studies that investigates teacher effectiveness in elementary and secondary education and is funded by the Gates Foundation and the U.S. Department of Education Institute of Education Sciences. With regard to healthcare, his current research investigates the quality of care in hospitals and labor markets for nurses and physicians, and he's funded by the National Institutes of Health and the Gordon and Betty Moore Foundation. Dr. Staiger was the recipient of the Arrow Award for the Best Paper in Health Economics in 2007 and the Eugene Garfield Economic Impact of Medical and Health Research Award in 2008. Doug is also a core faculty member of our Center for Interdisciplinary Health Workforce Studies and a key contributor to our research. So without any further delay, I'm going to turn this over to Doug, who will be presenting his work on spousal influence on the decisions of physicians to practice in rural areas. Take it away, Doug.
Great, thanks, Pete. Let's see if I can get my slides up. Show my screen. Are we getting it? Looks like you're not seeing my screen. Is that possible? Do you see my slides up?
Yeah. Well, I can see them, Doug. Can I talk?
Oh, you can. Okay, I'm not seeing it, so I'll assume it's working.
Yeah, it is.
It's working, Doug.
What happened to my, there we go. All right, good. So this is ongoing work, still under review, but with Pete Bierhaus, Dave Auerbach, who are longtime collaborators on nurse work, and 2 people from here at Dartmouth, David Goodman and Sam Marshall, who was at Dartmouth but now is off in graduate school at, I should remember, but someplace. Anyway, so let me just kind of give you an overview, a quick summary to start. Why is my screen not, oh, that's why. There we go. Okay, so here's the summary of what I want to talk about today. So everybody knows the difficulty on getting physicians to locate in rural areas, right? There's been decades of policy to try and attract physicians to these underserved areas. We've seen, doubling of doctors per capita, but still we're having troubles getting physicians to locate there. There is this parallel work that economists have gotten interested in about power couples, is the kind of catchphrase for it. Dual career couples, two highly educated people who are married, and there's been evidence that these kind of power couples are increasingly concentrated in urban areas because urban areas are the best place to solve dual career constraints, where both members of the couple have to find a high-end job, which is hard to find outside of big urban areas. So what this paper is doing is looking at this issue in physicians, and I'm going to show you some evidence about a dramatic rise in physicians with highly educated spouses. So a lot of physicians are now in these power couples, and that physicians who are married to a highly educated spouse are also much less likely to locate in rural underserved areas. So that trend up in power couples is the headwind that we're working against in trying to get people to physicians to locate in rural underserved areas. So let me walk you through kind of the evidence that we've put together on this. So first, let me start by talking about the data. The data I'm going to use for this first part, or actually for the whole thing, it comes from the census. They have large 1% samples of the U.S. population, so we can get a lot of physicians here, 1%. We're going to focus on working physicians between the age of 25 and 70, which is virtually all working physicians. We have data, 1% samples every year from every decade from 1960 to 2000. These are from the census long forms. And that's the total, about 20,000 total physicians over those decades. And then more recently, the census has, rather than just getting a survey, doing a long detailed survey once every 10 years, they've begun doing the American Community Survey, which is equivalent to the census long form survey, but it's done every year and gets 1% sample of the U.S. population every year. So from 2005 to 2011, we have the American Community Survey. How are we going to define a power couple? We're going to look at all these physicians, and you have information on their spouse and their spouse's education. And we're going to define a power couple if the physician's spouse has a master's degree or higher, master's, professional, or Ph.D. degree. How are we going to think about working in rural shortage areas? We're going to say you're working in a rural shortage area if you're working outside of a metro area, and the census identifies public use micro areas, PUMAs. And so we're going to identify, that's the smallest level of geography in this census data in the surveys. And so we're going to identify PUMAs that were rural shortage areas, and we're going to say you're a rural shortage PUMA if at least 50% of the rural population living in that PUMA is in a primary care health professional shortage area. And we determine that based on census block designation from HRSA. So we can take the HRSA data, we know every census block, we know how many people live in that census block, we know which census blocks live within each PUMA, and we can figure out in that PUMA, at least 50% of the people are in a shortage area. And so if you're in one of those PUMAs and outside a rural area, we say that means the physician working there is working in a rural shortage PUMA. Okay. So first, let's just describe power couples. We use this data just to look at what's been going on in the proportion of physicians married to a spouse who has a graduate degree. And this picture basically summarizes the trend. It's pretty dramatic, right? It used to be about 10% of married physicians had a spouse with a graduate degree. Now it's up over 50%, about 55% by 2010 have a spouse with a graduate degree, and just climbing straight up, right? So clearly there's been a huge rise, huge demographic change among physicians in terms of their spouses and their spouses' education. you might be interested, here's about a third of these are physicians married to other physicians. So, it's not, and that's increased kind of in step with physicians married to anyone with a graduate degree. But so, some of these are two physician couples, but 2/3 of these power couples are physicians married to, lawyers, Ph.D.s, et cetera. So that's been a big increase. You might imagine this is just overall among all physicians, for example, in 2010. The question is, will this trend continue? One way to ask that is to look at younger physicians and see, is this trend even bigger in the younger cohorts? Oh, I take it back. That's the next slide. Before I do that, one thing contributing to this trend is the growth of women. But that's not really the bulk of what's driving this, the growth of women physicians. So women is the top line in this slide. Women physicians have always been more likely to have a spouse, a highly educated spouse. So even back in the 60s, women physicians, 2/3 of them roughly had spouses with graduate degrees. And that's been pretty constant, but the proportion of physicians, of married physicians who are women, has grown from 4% to 31%. So that's contributed, right? We're shifting towards the physicians who are more, women, and women are more likely to be married to a spouse with a graduate degree. But the bottom line is the trend among men. So, it's just, actually most of what we're seeing in the overall trend is male physicians are more and more likely to be married to a spouse with a graduate degree. That mimics what's going on more broadly in the population in terms of, highly educated individuals are more and more likely, especially, highly educated men are more and more likely to be married to a highly educated spouse. This is what I was starting to talk about before. One question is this trend going to continue? One way to look at that is to instead of looking over time, look at recent data. So this is from data, the American Community Survey data from 2005 to 2011, and just separate physicians by their year of birth and look at the proportion of each birth cohort of the married physicians who are married to a spouse with a graduate degree. And you can kind of see the more recent cohorts, those born 1970 to 1975, over 60%, we're getting up close to 2/3 of physicians, of those physicians are married to a spouse with a graduate degree. So, as new cohorts enter that look more like these recent cohorts and the older cohorts start retiring, this trend's just going to keep going overall. And these younger cohorts are the ones who particularly rural areas are trying to attract. Okay, so the summary of that evidence just on trends is it's been this really steady growth in physician power couples, and it's continuing in the younger cohorts, so it's going to continue. Some of this is the trend toward women physicians, but that's not really the bulk of the trend. And one way to think about, how important this has been, all these figures were among married physicians, but it also turns out single physicians over this time rose from 14 to 24%. The power couples of all physicians, not just among married physicians, rose from 7 to 41%. So that means if you think about how many, if you think of the single and the power couples as the group that are going to be most difficult, and I'm going to show this in a second, most difficult to recruit to rural areas, that used to be 21%, now that's 65% of all physicians. So this is just a major change. We're left, if the rural areas are primarily looking for what you might call the old style traditional couples of a physician with a less educated spouse, married physician with a less educated spouse, that group is gradually disappearing. So those are the major trends. I want to turn now and then the rest of the time talk about the second piece of this, which is, are these types of couples less likely to locate in rural areas, rural shortage areas? So this uses the more recent data, 2005 to 2011, the American Community Survey, because that's where we have the best physician shortage and PUMA kind of data, geographic data. So what we're interested in is factors related to the dependent variable, which is, does the physician work in a non-metro part of a rural shortage PUMA? So that's what I'm calling a rural shortage area. And that is, and by the way, this is work, not live. The census actually tells you where people work. About just over 5% of all physicians work in these rural shortage areas. The raw data basically tells a story, right? If your spouse has a graduate degree, it's only just over 4%. For all the other married physicians whose spouse doesn't have a graduate degree, it's 7%, just over 7%, and single physicians, just over 4%. So basically, the singles and the power couple physicians are much less likely to be locating or working in these rural shortage areas than the other, and those are the groups that are growing. Right? So I'll show you a little bit just the, we do logit models that look at this data at the probability somebody works in a non-metro, in a rural shortage area, that adjust for demographics, and that's this table I'm about to show you that has odds ratios from that. So the first thing I want to focus on is, this is just the odds ratio of someone who's married and spouse has a graduate degree relative to the reference group as someone who's married and spouse does not have a graduate degree. So this is saying someone who's married and in a power couple is less likely to work in rural shortage area versus other married. And that's right there about, so the odds ratio of 0.62 means they're about 38% less likely to work in a rural shortage area than other married physicians. You might think, does this differ depending on whether your spouse, you could break the people whose spouse has a graduate degree into the ones whose spouse is another physician, and ones whose spouse is not a physician but has a graduate degree. And you might have thought, we thought going in, that perhaps two physicians, it might be easier for them to locate in a rural shortage area since they can both find work there, and that actually might work out. That turns out that's not true. Even the dual couples are just as unlikely. The dual physician couples are just as unlikely as other power couples to work in rural shortage areas. The singles look a lot like the power couples in terms of they're less likely compared to other married physicians to locate in the rural shortage areas. So the growth in singles is also reducing the probability that physicians will locate in these rural shortage areas. Everything else in this table is kind of what you might expect and things that have been documented earlier. Physicians who are minority, female, younger are less likely to work in rural shortage areas. That's all kind of more the standard. So the growth in females contributing a little bit towards making it more difficult, but even more important than that is the fact that females tend to be married to spouses with a graduate degree, and that has a much bigger effect on top of being female. So just to sum up, the basic lesson from this, or the main facts I think that we uncover, is that proportion of physicians married to these highly educated spouses has really grown. It's been very dramatic. And these kind of couples, these power couples, are less likely to locate in rural areas, presumably because of the difficulty of finding jobs for both spouses, that co-location problem, right? And that is the headwinds that we're swimming against. Any policy, holding all else equal, physicians are going to be less and less likely to locate in these rural shortage areas. So policy has to overcome that trend, and even more if it wants to increase the numbers of physicians locating in rural areas. I think the other thing that's interesting about this work is, I think a lot of the past policy has focused on what I think of as obvious kind of methods to attract physicians to rural areas, financial incentives, whether it's loan forgiveness or higher payment rates, add-on payment rates for working in these shortage areas. The issue here says, well, maybe trying to get at the fundamental problem might be an interesting alternative way to make it easier for physicians to locate in these areas. So if the main barrier is this co-location problem with your spouse, one issue that certainly many private hospitals in trying to recruit are obviously aware of and concerned with is trying to find career opportunities for the spouse. It's a little less clear how broad policy can help solve that problem, right? In the absence of that, the two obvious ones are, okay, this is, if you can't fight them, join them. If you can't get the physicians there, you got to figure out a way for them to practice from someplace else. So the telemedicine approach, which addresses that directly and says, okay, we understand these physicians can't locate in the rural areas, or physician substitutes like nurse practitioners. So it's kind of acknowledging that this is an uphill battle, that you're swimming against or sailing against headwinds here, and try to instead acknowledge that the physicians aren't going to be there because of this co-location issue, and find alternatives to having the physician in residence in the place. So that's kind of what we think of as the main takeaway from this work. Good. And that's it. I'm done.
Thanks very much. And appreciate your giving this first presentation during our webinar. Now, if you have questions for Dr. Staiger, please type them under the questions toolbar, which is at the right portion of your screen. So now that Doug has sort of set us up and described these demographic headwinds that are strong and significant and blowing very hard and preventing many physicians from moving to these rural areas, we're going to hear from Davis Patterson. And he's going to be talking about the training opportunities for medical residents and the decisions of residents to practice in rural areas. Before Davis gets going, let me just give you a brief introduction. Davis is the Deputy Director of the University of Washington's WWAMI Rural Health Research Center, and he is an investigator in the University of Washington Center for Health Workforce Studies. Prior to returning to the centers in 2009, Dr. Patterson spent 3 years at Battelle Centers for Public Health Research and Evaluation. At Battelle, he supported the Agency for Healthcare Research and Quality and the Centers for Disease Control and Prevention in developing hospital emergency preparedness, indicators, and evaluating public health department preparedness for emergencies and disasters. Davis is currently leading research projects at the Rural Health Research Center and Center for Health Workforce Studies at Washington, and he's examining the role and contribution of international medical graduates to care for the rural underserved and the effect of built environments on walking levels and physical activity among rural residents. His field of research experience includes conducting interviews of over 500 persons from diverse cultures and from all walks of life, both domestically and internationally. Davis is fluent in Spanish. He received his Ph.D. in sociology at the University of Washington, and we're very pleased to have Davis take it away now and talk about the training opportunities and challenges facing medical residents to practice in rural areas. Take it away, Davis.
Okay, can you hear me?
Coming in loud and clear, thank you.
Okay, great. Thanks for that extended introduction. So let me show my screen here. Oh, there we go. And I just want to start out by saying that the work that we're doing, that I'm going to be presenting, is hopefully providing a countervailing wind to some of the trends that Doug described. And so you can see my presentation. We're good.
Yep.
Okay, great. So before I get started, I want to just acknowledge my collaborators. at the WWAMI Rural Health Research Center, Holly Andrilla, Stephanie Ostergaard, Caitlin Morrison, and Sue Skillman, as well as a couple of collaborators who've been really central to this work, Dave Schmitz at Family Medicine Residency of Idaho and Randy Longenecker at the Ohio University College of Osteopathic Medicine. And this is work that's, okay, so I'm trying to see how to advance. Okay, there we go. This work's funded by the Federal Office of Rural Health Policy, and I also want to acknowledge Sean Finnegan at the Graham Center, who provided data in our analyses on from the National Provider Identifier database. So just to give you a roadmap of where I'd like to take us, I want to first talk about the context and aims of our study, and then get into some findings about residency programs, their characteristics, and where their graduates end up practicing. So this is a bit more of a program level analysis. We are going to be we are involved in doing a survey of graduates of what we're calling rural-centric residency programs as we speak. And so we hope to drill down into some of the issues that Doug got into, which are really fascinating. So I'll present those findings and then talk about some possible threats on the horizon, the impact of a single residency accreditation system, and then I'll leave you with a couple of resources. So as has already been mentioned, yes, hello?
Hey, this is Christy. Can you reduce the size of your slides a little bit? I don't know if everyone's seeing this, but we're seeing that some of the text is cut off. And maybe if you zoom out a little bit on the slide, it will show the full thing.
Okay, let's see here. I'm trying to, I have a zoom in option, but I'm not seeing how to zoom out. Let's see what happens.
I think you fixed it. That looks better.
Okay, all right. So let's see here. Whoops. So you can see it now?
I can, yes.
Okay, great. Thanks. Rural populations rely particularly on family medicine physicians to provide most of their physician care. And there's been work showing that trainees who are exposed to rural practice and also a broad scope of clinical skills are more likely to engage in rural practice, and there's a number of studies that show that. So what we really wanted to do was look at what we're calling rural-centric family medicine residency programs in terms of, do they offer a breadth of rural relevant training, where are they located, and how much rural training, what's the duration of the rural training that's offered. And then once we start looking at those, after we look at those characteristics of the programs, look at where graduates end up practicing in terms of rural and urban location. There are also other components to this study. It's a work in progress. We're looking at health profession shortage areas, as Doug was looking at, as well as practice and safety net facilities, but I'm just going to share the rural-urban findings. And so then we want to compare what the rural yields are for different types of graduates and different programs. So first off, I'll get into the program characteristics of these family medicine residencies, and by way of methods, we actually started out with looking at all allopathic, osteopathic, and dual accredited family medicine residencies. And then we wanted to zoom in and see which ones were either in a rural location, and that's self-reported, or according to rural urban commuting area codes or urban influence codes, so common geographic definitions, or had a rural track, and that was by self-report as well. So again, those who were either in a rural location or had a rural track, we surveyed that group, and that was 171 of the 583 family medicine residencies in the U.S. at the time. This was at the end of last year. And we got a 77% response rate, so that was 131 of those programs. Now, looking at the mission of those programs and their rural training requirements, 88% of those residencies said that they actively recruited applicants with an interest in rural practice. So, nearly all of them indicated some sort of rural mission. Of those, about 3/4, 74%, required rural training for some or all of their residents. And this was important to us. We were not interested in programs that only provided electives. We wanted to look at programs that required rural training. And specifically, based on some past work and just thinking about it intuitively, we thought, well, at least 8 weeks of rural training. That would be kind of a minimum rural dosage over 3 years that we thought a program, might need to be to have a greater impact. And so 58 residencies required at least 8 weeks of rural training. And now this is whether they were rurally located or urban. So our analyses that I'm going to present are based on those 58 programs that met these screening criteria, which I'm calling rural-centric family medicine residencies. And so first of all, in terms of a broad scope of practice, we asked about 15 different clinical skills. And let me see if I can use my pointer here. Okay. So and I apologize for these abbreviations, the acronyms. They are all related to emergency care, such as advanced cardiac life support. So you can see most of these residencies all provide a set of skills. A lot of them cluster in the emergency care skills, ACLS, PALS, comprehensive trauma and emergency care. But then as you go further to the right, you see fewer than 2/3 provided training in endoscopy and fewer than 2/3 in general surgery. And if you go further to the right, surgical gyne and operative OB were offered in fewer than half of these residencies. And so really these surgical and procedural skills over here are where there was greater variation between these residencies, which is important for us to note. So all rurally relevant or all rural residencies are not the same in terms of the training they provide. One of the things that we wanted to do was to look at where is the training that they're providing, both in terms of the block rotations, clinic sessions, and then programs that were located full-time in a rural area. And so we asked them, give us the zip codes of your rural training experiences, and then we geocoded those according to RUCAs. Now, the rural-urban community areas that's not the only definition of rural, and there are many ways to measure rural, but that's common in health services research, and we needed to use some definitions. So what we found was anywhere from 65% to 70% of the residencies' training experiences that were self-reported to be rural. So the residents said these are our rural experiences. They actually were rural according to RUCA codes. So that's this group over here. Over here on the left, these are residencies where all of the experiences, all of their block rotations, clinic sessions, or indeed if they said that they were located full-time rural, all of that training actually occurred in urban areas according to the RUCA codes. And again, what's the right definition of rural to be using? That's debatable. And what is rurally relevant in terms of, where the residencies are located or where these experiences are located? Is rural serving something that we should be looking at beyond just being a rural location? So for this part of the study, our first conclusions are that, we see that many of these residencies seek to produce rural physicians. They say that they do, but most of them required fewer than 8 weeks of rural training. And the programs varied quite a bit in terms of their coverage of rural relevant skills, and some of that rural training doesn't actually occur in rural settings if you look at the definition, the definitions provided by the RUCAs. So now let's look at where the graduates of these programs end up practicing. We had, of those 58 rural-centric programs, we found that 13 of those, about 22%, were actually too new to have any graduates. Their first residence started after 2010. So that's interesting. That's you know, a good sign in terms of expanding rural training. It reduces the sample size that we had available for analyses, but we still had about 440 graduates that were identified by the programs. So 60% of the remaining programs provided graduates for the academic years 2007, 2008 through 2012 and 2013. And so then we looked at, did these graduates go urban or rural based on where their residencies, the main program was located. Was it in an urban or a rural location? We also looked at some other characteristics, but I'm just going to show those analyses. We identified their locations using National Provider Identifier data, and then we geocoded them using the 2010 RCA codes, which are just out this year. So first of all, the overall trends we see at the end of residency, just under a third were in rural, and then the number starts going up, and these are years post-residency. Year 1, getting closer to a half. Year 2, 3, 4, 5, and 6, all at 50% or higher, actually ending up in rural practice. And that's probably not surprising, but it is at least double the national rate of all family medicine residency graduates. So, you know, the glass is at least half full in terms of the yields of these programs that have a rural mission. One thing we thought we would do is disaggregate the data, because we were wondering, you know, what's going on that's causing that upward slope? Does it apply to every cohort? And in fact, when we disaggregated the data by cohort, we found the same pattern of at the end of residency and then 1 year post, end of residency, 1 year post, 2 years post. There's this upward trend from going from urban to rural locations. But the interesting thing that we see here is that over time in these years, 2008 through 2011, the initial yield gets lower and lower, and then it starts to climb up again in 2012, 2013, and of course we don't have enough data to see where they're going to go out here. But this is interesting, and it sort of suggests that there's some, you know, period effects going on here, that maybe something historically is happening in this time period. And, you know, it makes me think about the recession, wondering if, and this dovetails really nicely with the work that Doug just presented, you know, do we have people that perhaps are in dual career couples, and it's harder to find jobs for both of them during the recession in a rural location? Or are people stuck in the homes that they were in during residency, some of them being in an urban area, and they couldn't move? But then that, you know, the trend seems to reverse itself here. So we'd have to see, and we're hoping to get more data to follow this out over time to see, you know, what's going on and if there's a recovery of the yield to rural in future years. Another interesting finding we found, and this is probably not surprising, but the graduates of programs that are based in rural areas, you know, nearly 2/3 of them start out in rural, and their persistence over 5 years is pretty high. They tend to stay there. A finding that we haven't seen before and that we were particularly interested to see is the urban-based programs, again, urban with a rural track of some sort. These graduates at the end of residency were, you know, almost all of them in urban locations, and then they increasingly go rural over time. And in fact, they don't completely close the gap, but they go a long way toward closing the gap with their rural residency counterparts, all the way up to 50%. So that was a surprising finding that we need to dig into some more. So our general findings for this part that are that, you know, rural practice yields increased in the first year or two post residency, and then they stabilized. The earlier graduates that we have data for were in rural areas at higher proportions than later cohorts. By the way, that trend is not significant, and it's probably due to sample size more than anything. So we are hoping to supplement that with more data to see if we can get a better handle on that. And the rural program yields to rural areas started higher, but the urban programs partially closed the gap over time. So now I just want to talk about some changes that are coming in graduate medical education, and maybe some storm clouds on the horizon. And so there is a merger going on, or it's about to start in 2015, and should be complete by 2020, and that is of allopathic and osteopathic residency accreditation. They will all come under a single system for accreditation, and there are some concerns. Allopathic residencies currently require a minimum of 4 residents per class, but osteopathic residencies can have fewer than 4 residents. And then dually accredited residencies currently must have both allopathic and osteopathic certified co-directors. So if you think about rural residencies that tend to be smaller and less resourced, it really begs the question of, are there threats to rural-centric graduate medical education under this new system, depending on what requirements are adopted in a single accreditation system. So can these smaller osteopathic residencies of fewer than 4 residents recruit more residents and a new allopathic co-director to maintain accreditation? Can they afford that cost? Or will these requirements change or be modified to ensure that rural training isn't threatened? Also, there is an allopathic or alternative training track designation in family medicine for fewer than 4 residents, and will that remain under unified accreditation? And are there other vulnerabilities in this new system? And we actually have a study that we're starting this year to look at some of these issues. So I want to leave just by mentioning a couple of resources to build a bridge from where we are now to where we might want to be in terms of rurally located training. First of all is the Rural Training Track Technical Assistance Program, and this has been going on for a number of years. I think we're in year 5, and it's a consortium of the National Rural Health Association, the Rural Assistance Center, National Organization of State Offices of Rural Health, and WWAMI Rural Health Research Center. It's funded by the Office of Rural Health Policy, and there's the website. And by the way, I'll make these slides available to anybody after the call, so you don't have to jot all this down. And so this program is intended to provide technical expertise and assistance to what are called 1-2 RTTs, and these are a special variety of residency. They're not subject to the Medicare cap on graduate medical education, and they are small. They can have fewer than 4 residents, and they typically have up to a year of urban and then 2 years of rural training. So they're special in a number of ways. So this program provides them technical assistance and tries to support developing new ones. We're building what we're calling an RTT master file of program and graduate data, identifying factors that are leading to either programs closing or resilience, keeping them open. And then the consortium also works to support student recruitment and build alliances. And there's a quick map I'm just flashing up of these. They're small, and they're small in numbers, but they're growing. And there are policy briefs available on our website and the program website, which is hosted at the Rural Assistance Center. And then finally, growing out of that is the RTT Collaborative, which is a nonprofit 501c3. And the purpose of the RTT Collaborative is to sustain health professions education in rural places through encouragement, peer learning, practice improvement, and delivery of technical expertise. And this expands on the initial RTT PA program, and it includes medical training in all its forms, graduate and undergraduate training, allopathic and osteopathic, those 1-2 RTTs that I was telling you about, as well as other kinds of rural training tracks. And eventually, in the spirit of team-based care, it's hoped that it will include other specialties in health professions. So these are resources, and I can certainly connect you up, or you can go to those websites and find the resources on these programs. And I think I will conclude there, realizing that we want time for questions and for either Doug or myself. So I'll hand it back to you, Christy and Peter.
Thanks very much, Davis. You gave us a lot of information and some, I think, as you said, some encouraging looks at the future and potentially some storm clouds as well. So at any rate, we have about 10 minutes for some questions, and I'm going to turn it over to Christine Friedman, who is our program manager at the center, and ask Christine to sort of guide us through some of the questions that we've received. Christine?
Sure, great. Thanks, Peter, and thanks for great presentations. We have a few questions. The first is for Doug. Question is, does choice of an MD or a DO program have any impact? Do we know anything about that?
We're going to check technically if we can reach Doug.
Hold on, sorry, Doug, I may have.
I think we muted you, Doug. Sorry.
There we go.
Are you there, Doug?
Excellent, I'm back. I just sent you an email to unmute me. So it's an interesting question, and it gets to the strengths and weaknesses of the data we're using. The data we use tells us nothing about the program that people trained in, so we don't know anything about the role of where people trained or the type of program, unfortunately, and how that drives decisions. All we know is this. In fact, we know very little about these physicians. We don't even know their specialty. So, it's a very high-level view of what's going on. The strength is it's great data on those physicians and big samples, but we just don't have that level of detail.
Okay, great. Second question for you, Doug, is can you repeat the definition of a PUMA?
Oh, so PUMAs, think of it as basically the census for these surveys. They try to identify as small as they can geographic areas. And so they take census blocks and kind of build them up into these public use micro areas that are roughly, I think, about 100,000 people. So within urban areas, they're quite small. In the rural areas, they can be larger. A big chunk of New Hampshire can be in one PUMA. But they do tend to, PUMAs are generally almost all rural or almost all urban. And so and other than that, they're just a census-defined geographic area that they think kind of makes some geographic sense, and that is large enough so you can't identify individuals, but small enough to be as useful as it can geographically. So it's better than a zip code, better than a county, not as good as a census block.
Okay, great. Next question also for you, Doug. Does choice of educating at rural co-located programs impact choice? Assumes that the spouse is found at the same school.
So the rural so again, this is an issue that we don't have data on, but it's interesting. So I see you're kind of, I assume you're kind of getting at trying to get people who have a spouse who wants to be rural. Sounds like that question is kind of about that. We haven't thought at all about that issue, and in some sense we don't know how to get at it with data. It certainly seems sensible, and there's other studies out there that have noted that if you're married, if either you or your spouse grew up in a rural area, it makes you more likely to move back. And we just don't know. I know most physicians are married. I think the median age of marriage for physicians is 28. So they're still getting married, fairly young. Most of them will still be in their residency at that point. So you could imagine that, you know, if the rural residencies should be trying to link up their physicians with a spouse that will keep them in the rural area. But I'm not sure that's a policy that that can be broadly pushed by the federal government, for example.
Thanks, Doug. But it did. I was thinking of when Davis was talking in that first group that he was analyzing, where only the residents spent 8 weeks in rural training. And I was thinking, well, that doesn't give you much time to look for a spouse or to have to find a spouse. But you're right. That's another conversation. Christy.
Okay, and then I have one more for you, Doug, and then I think we'll have a couple for Davis. Do you know of any collaborative efforts between rural universities and rural hospitals to match physician spouses with academic positions at rural colleges? We are currently working with a network of colleges and universities in Ohio to find jobs for spouses of academics in other colleges. I'm wondering what mechanisms exist to include physicians in these networks.
You know, I don't know of anything like that, and I think it's an excellent idea, right? Like, because part of this is trying to get, you know, one small rural town can't solve the problem, but the more there's a collaborative to try and do this matchmaking and try and, you know, a state or a region can set up the infrastructure that makes it easier for physicians to find jobs for their spouses. And I haven't heard of that. In fact, I didn't know that colleges were doing this, although it's a natural thing to come up for academics as well. You know, we face this all the time at Dartmouth. So I think it's a great idea, but I just, as far as I know, I don't know of anybody who's doing that. There probably is somewhere, but I just don't know about it.
Okay, great idea. All right, for Davis, did you account for or measure the influence of federal or state loan repayment programs as an incentive for practice in rural, medically underserved areas?
That's a great question. We don't have the data for this analysis because this was program level data and then NPI data, and so that information isn't in there. But what we're planning to do, or what we are doing, is to survey all of these graduates from the program, so the 440 roughly graduates. And so we're going to be asking them about their background characteristics, the life course characteristics, aspects of their training, and then we will be asking them about incentives to practice in rural. One thing that I can say on that is that, excuse me, we also have data that looks at U.S. medical graduates versus international medical graduates, and of course, some of the international medical graduates that came on J1 visas can get waivers if they practice in an underserved area. And when we split those numbers out, we don't have them by visa type. We just have all international medical graduates, so that would include U.S. citizens that did their training, their medical school training abroad. But you know, it certainly nets a number of IMGs who could be on J1 visas initially, and so we disaggregated those to see, you know, is there a difference? And the IMGs look a little different. They tend to be in rural at slightly lower numbers than the U.S. medical graduates, but in no year post-residency was that statistically different, significantly different. So, yeah, those are definitely questions that we want to look into in more detail, though, to understand what's behind these trends.
Great. One more for you, Davis. Are medical residents who originally came from rural area more likely to practice in a rural area?
Yes, there has been research on that, and that's one of the factors that we want to, I guess, further substantiate, but also maybe look at in combination with some other characteristics of these graduates. In other words, we can't just only rely on recruiting people that are from rural areas and getting them to go back to rural areas. I think we need to also look at factors that can influence people that may have a rural interest or have had rural experience, that get rural experiences in medical school or even in high school, medical school and in residency, and see if there are ways, there are characteristics that distinguish the ones who end up going rural, so that we can see if there are policies to encourage those, to make that more general.
Okay, great. We have time for maybe one more question, and then we'll have to end there. What other validated influences other than dual advanced degree couples are driving practice location choices, and how can we know the relative influence of these variables? And I know that's a big question for maybe 2 minutes of talking, so if maybe you guys want to take a quick turn and you can both answer that question shortly.
You want me to start with? I mean, there were other things that we saw certainly in our data, you know, the other demographic kind of factors that are, and that have other, you know, have been found over and over again, like, you know, gender has an independent effect on addition to being the power couple, so women are less likely to go there, to go to rural areas. You know, the single, minority, young, all those kind of things are at work. But you know, none of those are that interesting or necessarily, you know, you can't influence them with policy. It might help people thinking about who to target for recruiting purposes or for training. You know, you need to have the kind of people in training programs who are likely to actually locate there in rural areas. But do you want to, David, maybe I'll pass that to you to see if there are other things I'm not.
Yeah, what I would, 1 minute.
What I would add to that is that there is work going on looking at how to make rural places themselves more attractive. And in fact, one of our collaborators, Dave Schmitz, does a process. It's called the Community APGAR assessment, and they've been to, he and Ed Baker have been to a number of rural places looking at factors that could help them recruit and ways that they can, you know, improve their attractiveness in all aspects of the community, not just, you know, what the practice conditions and those sorts of things. So there's that angle that you know, we can approach as well.
Great.
All righty. I want to say thank you to all of you who participated in today's webinar, and especially to thank our two presenters, Dr. Doug Staiger and Dr. Davis Patterson. We appreciate your time and your research, and I think this has been an outstanding webinar. Now, remember everyone, our next webinar will also be on a rural-related themes. It will be on October 22nd at 2 p.m. Eastern Standard Time. Stay tuned for details. They'll be forthcoming from myself or Christy. So let me again say thank you, and we'll talk to you again very soon. Have a good afternoon.